And let's talk about orthopedics. And you know there are a lot of moving pieces and parts in you, and so we have a lot to talk about in orthopedics. So let me try to make this as painless as possible for you. Here's what we need to talk about. I got to make sure that you know the different most common forms of arthritis and how you might diagnose them. So we have to talk about osteoarthritis. We need to talk about rheumatoid arthritis and that workup. And then we need to talk about something that I call Monday morning arthritis, which is what? Gout, right? So we'll talk and compare those. Then we're going to move to the upper extremity. We've got to talk about some common shoulder problems. People come in with shoulder complaints all the time. And if you're like I am, I always found the shoulder very difficult to assess. So I'll show you one easy way, I think easy way to look at shoulder pain or do an assessment. Then we're going to move and talk about some elbow problems. Epicondylitis, very common. You need to know about it for your practice as well as on the exam. There's a common wrist problem. What do you think it is? Carpal tunnel, a quick review of that. And then we're going to look at a couple of hand issues that I think you need very much to see. We'll move to low back pain. You know, we could probably spend 3 days on low back pain. We have only a couple of minutes. I want to give you what you need, especially with regard to a straight leg raise, which I think you'll see again, and also with sciatica because it's so darn common. Then we're going to move to the lower extremity. You have to be able to know how to assess a hip, and so I'll make sure you can do that. We'll look at an ankle with problem. What problem will we see with an ankle? A sprained ankle. Obviously, any joint can become sprained, but the ankle it just happens to very often. Excuse me. We'll look at a couple of foot issues, common ones that you see all the time, a toe problem, and then I'm going to show you 2 5-second videos, excuse me, on a knee exam. A positive anterior drawer and a positive posterior drawer, because when you see the 5-second video, all of a sudden you got it, all right? When we're done with that, we'll take a break, so let's get going. You ready? I think if you see the pictures of an arthritic joint, I think you got it. So let's take a look. The joint on the right is a normal joint, and here's how we judge joints. We look at bone density. This one has good bone density. We look for joint space, which is what you see right here. And then we look for the presence of cartilage. And when a joint has those 3 characteristics, we typically say it is a normal joint. Now, what does it look like when a patient has osteoarthritis? Well, take a look. They still have good bone density, but 2 things happen. We begin to lose joint space, and sometimes the cartilage is completely gone. And that is the case with this picture on your right. Now listen, if you were to x-ray the picture on the right, I am pretty sure that when you looked at the x-ray, or a radiologist or anybody else did, they would use this term, listen, bone on bone. So look, here's bone on bone, and that's characteristic of a joint that's been affected by osteoarthritis. The joint in the middle is characteristic of a patient with rheumatoid arthritis who has not had the benefit of those new anti-RA drugs. Let me show you what their joints look like. The first thing you might notice about the joint in the middle is a gross amount of erythema and edema about the joint. That should get your attention first. But you know what else? Look at what's happened to bone density. There's a loss of bone density, and obviously joint space is gone, cartilage is gone. This is a joint that has absolutely been ruined by rheumatoid arthritis. So if someone were to ask you which of these 2 patients, an OA patient or an RA patient, would profit the most from anti-inflammatory meds like prednisone or one of the others, absolutely, the rheumatoid arthritis patient is the one who profits the most because that is truly an inflammatory disease. So let's look at osteoarthritis. In a nutshell, if you had to describe OA, I am pretty sure you would use these words. The first thing is you have to realize that patients come in to see you who have osteoarthritis because they hurt. They're in pain. A lot of people have osteoarthritis in joints without symptoms. They never darken your door. People with osteoarthritis who have pain secondary to their OA are the ones who will come in to see you. Typically, they tell you that they feel better when they don't move and it hurts when they move. That's interesting because one of our first line interventions with these patients is to make certain that we get them on an exercise program. Exercise not only increases range of motion of joints, but it strengthens soft tissue, which helps the joint support itself a little bit more. We'll talk about interventions in a minute. There's always a question that you ask a patient who has a question of or a complaint of joint stiffness. The question that you always ask is, how long does your joint stiffness last? Typically in a patient with osteoarthritis, they will tell you that the joint stiffness lasts less than 60 minutes. To be honest with you, statistically, their joint stiffness goes away within 30 minutes. But when you open a book or some learned authority, they typically give you that 60-minute cutoff or time frame. What about tenderness? When you examine the joint, it's not unusual to find tenderness when you palpate it. When you move the joint through its normal range of motion, what do you hear? Crepitus, right? So crepitus is what you often hear. It's the popping of a joint, and that's the word we use to describe it. If you get an x-ray, there are three things that you might find. One is, it may be on the report, unless you look at it, a finding of a joint effusion. So that's not unusual in these patients. It is not unusual on x-ray to find the presence of osteophytes. What is an osteophyte? It's a calcium deposition, right? When that calcium deposit or spur is in the lining or the cartilage of a joint, it will absolutely ravage the joint. So that finding of an osteophyte is not unusual. And then finally, we've already talked about joint space narrowing, which will be evident on an x-ray from wearing away of the cartilage. So here's my question for you. A patient suspected of having osteoarthritis presents with joint pain. What joints are not typically affected by osteoarthritis? Well, I'll tell you, the most common joints are the fingers. And that is a joint where osteoarthritis initially appears in most patients who have it. The knees and hips are commonly affected because they are weight-bearing joints, and that's what's typical of osteoarthritis. And finally, loads of people have osteoarthritis in the spine caused by osteophytes that create loads of pain. So which joints are typically not affected? It's the elbows, right? There are two terms that I think you should be familiar with. One of them is called Bouchard's nodes, and the other is Heberden's nodes. So when you look at this picture of the hand, I've got one of a hand with skin on it and one with just bones. I always remember that Bouchard's nodes affect the PIP joint right here, as opposed to Heberden's nodes that affect the DIP. And an easy way to remember that, I guess it's easy, is that B comes before H in the alphabet, and proximal comes before distal. You got it? So that's the way my crazy brain remembers it. I remember that B, Bouchard's, comes before H, Heberden's, and proximal comes before distal. You got it? So that's the way I remember it. Why is it significant to know about Heberden's and Bouchard's nodes? Well, very often our patients who have Heberden's nodes are the people with osteoarthritis. Most of the time, our patients who have Bouchard's nodes are ones who have rheumatoid arthritis. All right? I would be willing to bet you that we have somebody or multiple people in this room who have Heberden's nodes. And I would be willing to bet that if you look at your hands and you have them, that you are probably asymptomatic. Those are the joints that are typically affected first with osteoarthritis and don't always become symptomatic, at least not initially. How do we manage osteoarthritis? Well, here's what you have to consider. It is a chronic disease. So if you've got it today, you're going to have it in 6 months, in a year, and 10 years down the road. First line treatment and all of our management guidelines comes from the American College of Rheumatology. Their recommendation always for mild to moderate osteoarthritis is exercise. Get these people moving and they will feel better. In addition to exercise, weight loss if that's appropriate. But look, here's the deal. It is hard to lose weight. It's very difficult to lose weight if you can't move to help burn up calories. So these patients, you will find, will have a difficult time trying to lose weight. If they know how to manage their disease, It will certainly help. So patient education obviously is beneficial. What about heat in the line of non-pharmacologic management? Don't ever underestimate the value of heat in patients with osteoarthritis. So you got to get going with these interventions. These are easy. People can read them and get them on the internet. But this is where you come in. Where you come in is where drugs begin to be involved. The American College of Rheumatology in 2012 gave us these guidelines about management of this chronic disease called osteoarthritis. They said, you know what, you really ought to start with acetaminophen. Initially, patients will use it PRN. When they hurt, they take it. Then after that doesn't help anymore, the recommendation was to use acetaminophen on a scheduled basis, meaning keep a little bit in their symptom to try to give them some type of relief. When acetaminophen on a regular basis no longer provides relief from osteoarthritis pain, the guidelines say bump up your therapy. Move, unless it is contraindicated, to an NSAID, a nonsteroidal anti-inflammatory drug. The way those work is like this. When you give these drugs in low doses, they provide analgesia. When you give these drugs in high doses, you get the anti-inflammatory effect of them, but you also get more of a risk of side effects. So the recommendation when you use NSAIDs is not only to use short to medium acting ones, but generally you want to start at a low dose. So let me tell you what I mean by low and high dose. If you take ibuprofen, 200 to 400 milligrams, you're not getting a drop of anti-inflammatory benefit. You are strictly getting analgesia. The same is true of naproxen. When you take naproxen at 220 or even 440 milligrams, you are getting the analgesic effects of that NSAID. It is not until you get the high dose of NSAIDs that you get the anti-inflammatory effect. And to be honest with you, in your older patients, I'm not sure I ever am brave enough to go up to a high dose. So with osteoarthritis and pain, you shoot for analgesia. You got it? You don't need to go up to that high dose for the anti-inflammatory effect because, as I showed you, this is not an inflammatory disease. All right? So just to give you that perspective, here's what they recommend. Try the patient on one NSAID for 2 to 4 weeks and see how they do. If they tell you ibuprofen does nothing for me, try them on a different NSAID. Maybe try some naproxen. Maybe try some celecoxib, some meloxicam. But ACR says if you have no relief on 3 different NSAIDs with a reasonable trial, you need to send them to somebody else for steroid injection unless you do that. You got it? Now listen, I got to make sure you have an appreciation for something. You should be very, very careful in prescribing an NSAID long-term, typically to an older adult. There are 3 things that you should worry about a lot. When you give an NSAID chronically, what is the first problem you think of? GI issues, right? A GI bleed. Keep thinking of that. The reason patients are at increased risk for a GI bleed is because NSAIDs inhibit prostaglandin synthesis. And prostaglandins are what line your stomach and keep you from digesting your own stomach. Like, I'm sure you don't stay awake at night wondering, why don't I digest my own stomach? Everything that goes in it gets digested. Well, it's because you have prostaglandins. Who remembers the drug named Vioxx or Bextra? Raise your hand. You remember that drug? You know why that drug is no longer on the market? It was an NSAID. It was associated with an increased risk of MIs. So when you give an older adult an NSAID, not only should you be worried about the GI side effects, I want you to worry about the cardiovascular side effects. The third reason you should be very careful in putting an NSAID in an older adult is because of the kidneys. And I told you this morning when we had Mr. Jones, the cardiovascular lecture, Mr. Jones, we were worried about his kidney function. I told you I'd pull him off that naproxen. But let me tell you why. NSAIDs not only inhibit GI prostaglandins, but NSAIDs inhibit renal prostaglandins. As long as your kidneys make prostaglandins, you know what happens? You get renal artery dilation. You know what that assures you of? Great blood flow to your kidneys. When you stop making renal prostaglandins, you begin to get renal artery constriction, and what does that do to blood flow to the kidney? It decreases blood flow severely to the kidney. Consequently, not only do we worry about GI side effects, we worry about cardiovascular side effects. Please don't forget about the kidneys, especially in your older adults. So NSAIDs, be careful with them. Everybody with me? All right, you will see loads and loads of osteoarthritis. What about rheumatoid arthritis? I'll be honest when I tell you, rheumatoid arthritis is a completely different beast than osteoarthritis. Look at why. Look at that word right there. Autoimmune. Rheumatoid arthritis is an autoimmune disorder, and look at how it's described. The first word I want you to look at is this one. It is a polyarthritis. What does that mean? It affects multiple joints. It is a peripheral polyarthritis. What does that mean? It typically does not affect the spine. The spine is usually spared. It affects arms and legs and peripheral joints. And then look at the third word that we associate with rheumatoid arthritis. That word is symmetrical. That means if it affects the right wrist, it affects the left wrist. The right elbow, the left elbow. You got it? So a symmetrical, peripheral polyarthritis, that is what describes rheumatoid arthritis. Now, one of the most important things for you to do if rheumatoid arthritis is in your differential with a patient is always to get an excellent history. I want to know, does anybody in your family have any autoimmune disorders? And I'm going to ask them, lupus, scleroderma, rheumatoid arthritis, anybody in your family have anything like that? Make sure you get a good history. This is what you will look for. Certainly you look for peripheral polyarthritis in more than 2 joints. So 3 or more joints is what we typically look at. And almost always, one of the joints affected is going to be the hands. So I want you to look for that. But this is one darn hard diagnosis to make sometimes. It's difficult because some other diseases can present with a polyarthritis as well. I am thinking of lupus. I am thinking maybe of scleroderma. When you ask these patients about their morning stiffness, they will tell you that it lasts a lot longer than 60 minutes. Our OA patients, less than 60. RA patients, typically more than 60 minutes. And sometimes they'll tell you, sometimes I don't loosen up until after lunchtime. So sometimes several hours. Something that you will notice with the joints in rheumatoid arthritis is that they swell. They can be warm, sometimes very red. And you'll look at those joints and realize these are very angry joints. A criterion that the American College of Rheumatology insists on being present for this diagnosis to be made is that the symptoms have to have lasted at least 6 weeks. So I have a picture here for you of the hand joints just to remind you about the reason we call rheumatoid arthritis the crippling arthritis. It's called the crippling arthritis because typically it affects hands, wrists, one of the metacarpals. It affects these joints, the carpal metacarpal joint, simply because it inhibits your ability to take care of yourself, which is why the word crippling comes up. When we talk about osteoarthritis, what's the term we use to describe it? The wear and tear arthritis. This is not wear and tear. This is a crippling arthritis. So let's talk about why that criterion of at least 6 weeks of symptoms must be present for diagnosis. Let me see if you remember this. There is a viral exanthem that everyone in this room, I'll bet you had when you were a little boy or girl. I'm sure I had it too. If you as a little 4 or 5-year-old got this viral exanthem, you got big rosy cheeks and maybe a lacy macular rash. If your mama got it, or your first grade teacher got it, or your kindergarten teacher got it, they didn't have red rosy cheeks and macular rash. Your mama or your first grade teacher ended up with a peripheral polyarthritis, such that she may not have been able to get out of the bed for 2 weeks, 3 weeks, 4 weeks, or up to 6 weeks. What is the name of that viral exanthem? Fitz disease, right? Fitz disease. Every little kid gets that, and I bet you we all got it. If an adult gets that disease, it is not unusual for them to develop something called a viral polyarthritis. We would never want to put a diagnosis of rheumatoid arthritis on the chart of somebody like that, because let me tell you something. It is easier to expunge a criminal record than a bad diagnosis on a chart. And I am not kidding you. So anyway, we want to make sure that what's in your differential is not a viral polyarthritis like that one. Listen, do you watch well, you already told me you don't watch commercials. I'm going to have you watch one this afternoon. No, not really. You know that commercial with Phil Mickelson, the golfer? You know what he says he has? Psoriatic arthritis. Sometimes that is going to be in your differential because it's a peripheral polyarthritis. So there are a lot of things that can be in your differential with rheumatoid arthritis, which is why I tell you this is not an easy diagnosis to make. So you are going to get these patients referred to rheumatology, but I will bet that you will initiate the workup in primary care. And this is what we often get. You're going to get a rheumatoid factor, but here's the trouble. Everybody with rheumatoid arthritis doesn't have a positive RF, and some people who don't have rheumatoid arthritis have a positive one. So that's not a confirmatory test. As part of your workup, we typically get these anti-CCP antibodies. That might indicate rheumatoid arthritis if they're positive. We typically get some of those acute phase reactants. They're very elevated in patients who have an acute inflammatory something going on. We get a SED rate and a CRP. You probably will get an ANA, but that doesn't diagnose rheumatoid arthritis. What might it do? It might exclude lupus as the reason they're having these symptoms, because a lupus patient can come in just like these people. And then finally, we get a general measure of how well this patient is doing otherwise. We typically get a CBC, a metabolic panel, sometimes a uric acid level. What are we thinking about? Gout, polyarthritic gout. So there's a big workup that goes into this diagnosis. These certainly are fair game for you to check in primary care, but to be honest with you, these people need specialty treatment and they need referral. So why do they need specialty treatment and referral? Because the drugs that we use to manage rheumatoid arthritis are not what we used to use 10 or 20 years ago. You know what we used to give people 10 years ago or 15 years ago? When they came in and were not so symptomatic, we gave them high doses of NSAIDs. We gave them prednisone. You know what we know now? The greatest amount of damage to joints in a patient with rheumatoid arthritis occur early in the disease, which is when we want to get these DMARDs on board. What's DMARD an acronym for? Disease-modifying anti-rheumatic drugs. The reason those drugs are now first line for treatment of rheumatoid arthritis as opposed to prednisone or NSAIDs is because these drugs save joints. They preserve joint function. So that's a drug that patients need to get in them, and most of us will never be comfortable prescribing these in primary care because they're not the safest drugs on the block. When you give DMARDs, people have got to have regular follow-up with CBCs and hepatic panels and kidney issues. You just can have loads and loads of issues. So what is your job? Start the workup, have an index of suspicion, but to be honest with you, you got to get them into rheumatology. You probably already know that we have a nationwide shortage of rheumatologists. We do. So how long does it take to get them in? It takes a while, all right? So it does take a while. So listen, if you had to compare RA and OA, I think this would put it in a nutshell for you. The joints that are typically affected vary. You see them? The presence of Heberden's nodes varies. The condition of the joints varies. The stiffness, the question you always ask about, varies. And finally, the labs will be extraordinarily different. So you should never mix up an OA and an RA patient. Although I'll tell you, it's difficult to make a diagnosis of rheumatoid arthritis. It's not always the easiest thing because so many other autoimmune disorders can present with some of the same positive results, right? Everybody good on those two? There's another common form of arthritis, and I call Monday morning arthritis, and it is gout. And gout is one of those things that in the United States today, the CDC describes the incidence of gout as epidemic because so many people have it. And if you haven't seen a case in a clinic where you're working, I guess you just haven't seen enough patients. But gout is all over because it is so darn common. The joints that are most typically affected by gout are which ones? Big toe and the fingers. And here's why. When you have gout or an episode of gout, an acute episode, you get the formation of a uric acid crystal. It's like a little grain of sand. And it precipitates out because of gravity to your lowest point, which happens to be the big toe. But there's another reason we see it in the big toe and in the fingers. It's because the most distal joints in you are the coolest joints, where uric acid crystals can form way more readily and rapidly. So when you see gout, it is way more likely to see it in a distal peripheral joint like fingers or toes. And so that's when we see it. When you begin to see gout in other joints, you need to start thinking of something else going on. How many people have ever seen gout in a hip? You never saw that. Your hips, this is going to come out wrong, your hips are too hot, right? It's too warm. It's close to your trunk. You don't have the precipitation of uric acid crystals in warm joints. So when you see gout that forms in elbows or shoulders or hips or knees, you need to think about something else going on with that patient. Look at why we see so much gout in the United States. Take a look. I don't know what you had for lunch, but I had a high purine diet. There was sausage on my red beans. That's high in purines. What about diuretics? I'm not on one of those, but if you take a diuretic and you excrete water, what does that do to your uric acid concentration? It drives it up. It makes you more likely to precipitate a crystal. What the heck does aspirin do? Because it definitely contributes to gout precipitation or uric acid crystal precipitation. What does it do? Aspirin inhibits your ability to excrete uric acid. You got it? Aspirin inhibits your ability to excrete uric acid. So if you've got high concentrations of it because you're on a diuretic and you're not excreting it so well because you're on an aspirin and you eat a high purine diet and oh yeah, Mardi Gras is coming, where you might consume alcohol, well, you're going to get an episode of gout. So it's just how things go. So we see loads and loads of it. Well, look at this question. Which medication could be initiated during an acute attack of gout? What would you give a patient who came to see you who had an acute attack of gout? Could you give number one allopurinol? No. Suppose you didn't know you weren't supposed to give that and you gave allopurinol anyway. Do you know what would happen to the patient? They would begin to spit out uric acid crystals that would precipitate in joints where you never see gout, like elbows, knees, hips, shoulders. So if you give allopurinol too soon after an acute event or acute episode of gout, you'll begin to see people come in with gout very soon after a previous episode, and I'll tell you what, they're going to look at you and say, I'm never taking your medicine again. So how do you know when to start allopurinol? Typically, we make sure that all the acute symptoms have completely resolved, and if you measure the uric acid level and it is elevated, you're going to wait until that uric acid level comes down, all right? But drink water, water, water is what we tell them to do when they have an acute event. So look back to my question. Which medications could you initiate during an acute attack? Absolutely not allopurinol. Naproxen is a good idea. Indomethacin is a good idea. And honestly, prednisone or even a prednisone injection in an affected joint may be a good way to go as well. So 2, 3, and 4, I think, are your best answers. So look at during an acute attack. You know what drugs to give now. The other thing I would add to your treatment of a patient with acute attack is to make sure that they drink. And I usually look at them and say, I'm not talking about beer, Mr. Boudreaux. Water is what I want you to drink. All right? Everybody good? All right, let's talk about the shoulder joint. So a very dear friend of mine is an orthopedic doc. And I remember telling him or asking him many years ago, I said, listen, I am struggling with my assessment of a shoulder. I said, what do y'all do? Y'all meaning orthopedic docs. And he said, Amelie, this is what you need to do. He said, when a patient comes in with shoulder pain, the first question you ask them is, where does your shoulder hurt? So if they tell you it's lateral shoulder pain, he said you should know the top 1 or 2 things that produce lateral shoulder pain. Work them up. If that's not what it turns out to be, then send them to ortho. He said ask them where their shoulder hurts. If it's anterior shoulder pain, he said you should know the top 1 or 2 things that produce anterior shoulder pain. Work them up. If that's not what it is, they need to go to ortho. And so I looked at him and said, okay, I got it. What about posterior shoulder pain? And he told me what you already know. Posterior shoulder pain is almost never a shoulder problem. Where's the problem? The neck, right? So with that perspective about asking where your pain is, let's look, excuse me, at the shoulder joint. I want you to look at a patient who comes in to see you who has shoulder pain secondary to an acute event. So here's your guide. It starts out with select all that apply. Acute shoulder pain secondary to trauma should be assessed by what? Always we get a history of the injury. Tell me what happened. Mechanism of injury is huge when we talk about orthopedics. Gentle palpation is always in order to find out if there's point tenderness, which would indicate a what? A fracture, exactly. Certainly you're going to x-ray the affected shoulder because this occurred in the setting of trauma. We always follow up with an x-ray. And then finally, assessment of degree of pain is probably very important. But to be honest with you, some people are very stoic. And so they don't let on that they're in as much pain as they really are. So what would I circle? Certainly all 4 of them in the setting of acute pain. Now, most people who come in to see you with shoulder pain have chronic pain, or it's been hurting for 2 weeks or 3 weeks, or this is a shoulder that's been giving me trouble for years and it comes and it goes. So here's how you work them up. When you ask them, where is your shoulder pain? When they tell you that it's anterior, look right here, anterior shoulder pain, or lateral shoulder pain, mean going into the deltoid, the top 2 things that you should consider in this patient is impingement syndrome, because that is the most common cause of shoulder pain in an adult. What the heck is impingement syndrome? It means that when you raise your hand at or above the level of your shoulder, everything inside gets closer together. So look at what gets closer together. When you raise your hand at or above the level of your shoulder, you get compression of the muscles and tendons of the rotator cuff and the subacromial bursa. So everything in there gets closer, and that's what the word impingement means. So that's a common cause of anterior or lateral shoulder pain, but the other one is certainly the rotator cuff. Everybody who has a rotator cuff injury can have a varying degree of injury. So the rotator cuff is made up of how many muscles? Look, it's after lunch. How many muscles? 4 muscles, right? So a minor injury to a rotator cuff can be a strain. You keep those people. A less complicated injury, the rotator cuff, can come with a tendinopathy. We call it an uncomplicated tendinopathy. You can keep those people. Sometimes you get people who have rotator cuff tendinopathy. Look, it says calcific. What does that mean? The formation of an osteophyte is what has caused the tendinopathy. And then finally, if there's a tear, you need to send those patients somewhere. So rotator cuff pathology can have a wide spectrum of not so bad to somebody who certainly needs help from ortho. So look at your 2 most common causes of anterior and lateral shoulder pain. It certainly is impingement syndrome, and it is rotator cuff tendinopathy. The complaint that patients who have either one of these will have is that when their arm or their hand gets at or above the level of the shoulder, they have pain. And these are the 2 most common things that you should consider and certainly work up. So how do you help these people? Well, of all the joints that you want to make sure continue to move, because remember, joints are made to move. Of all the joints that you want to make sure continue to move, it is going to be a shoulder. If they came in with an acute presentation of something, ice is always in order. Otherwise, heat helps these patients very much rest from whatever the aggravating or injuring activity was. NSAIDs may be of help, But your greatest benefit in these patients is going to be to give them exercises that will help the soft tissue and muscles strengthen, because it supports the shoulder joint. So that's why PT is in order. That's why pulling good shoulder muscle exercises off the internet or one of your books is always in order with these patients. If they are not better within a couple of weeks, or depending on how impressive or remarkable their presentation was, you will need to get them referred somewhere between 2 and 6 weeks, maybe to PT. PT does great work with these people. Or for more severe injury, obviously orthopedics. So impingement syndrome, rotator cuff pathology. Here's a question for you. A patient complains of pain in his left shoulder with stiffness, and he's got a significant loss of movement. Like he just can't get his shoulder up, his hand up. What do we call that? It is called capsulitis, adhesive capsulitis, very, very common, number 3. We call it a frozen shoulder. That's what adhesive capsulitis is. So look at my next question. What disease is frequently associated with a frozen shoulder? And it's going to seem very bizarre to you, and I can't even tell you why. But you talk to any hand, arm, or shoulder surgeon, and they will tell you, these are the patients I see. Who are they? Diabetics. Every day of the week. So one of your take-home points about shoulder pain is when the shoulder pain patient comes in and they have diabetes, you need to be aggressive in getting them to move. You know the exercises you do? You get them to put their hand out like this and use their fingers to walk up the wall. You better keep that shoulder of a diabetic moving. Those are the people who end up with the most severe shoulder problems. Everybody good on that? Let's take a look at this next patient. A patient has shoulder pain with weakness and loss of strength in abduction, meaning taking the arm away from the body, is not related to a lack of effort. What's a likely diagnosis? With shoulder pain, weakness, and loss of strength, there is one thing that you should think of always, and it is a tear in the rotator cuff. You got it? That is always what you think of. Well, there are 2 more causes of anterior and lateral shoulder pain that you just have to know about because they're so darn common. They involve osteoarthritis in the shoulder. I have a patient who is she and her husband are fly fishermen, and they fish just constantly. And if you know anything about fly fishing, you know that the shoulder joint is in constant motion, all right? So she and her husband both have severe calcific tendonitis. They have osteophytes that have formed in the shoulder from just repetitive injury, I guess is what it is. So listen, these patients typically present with symptoms that are anterior and lateral. It is not unusual with that presentation, and it is with these people, to have osteoarthritis in that joint. How will you diagnose that? You get what? An x-ray, right? So it'll find the presence of that osteophyte, and boom, you got your diagnosis. Here's what most people forget about the shoulder joint. There are 2 joints in your shoulder, at least 2 joints. Look, one of them is the AC joint. It is right here between the acromion and the clavicle. Look, here's your acromion, and here's the clavicle. The place where these 2 joints come together is called the AC joint. That is a common place for an osteophyte to form. It can produce anterior shoulder pain. Another common place for an osteophyte to form the shoulder is the glenohumeral joint. The GH joint is right here. It's where your shoulder connects to your trunk. That produces anterior shoulder pain. So with a complaint of anterior shoulder pain, you got to get an x-ray, you'll find an osteophyte, and boom, you got your diagnosis. All right? So pretty darn easy. And then, of course, with a trauma, it is not unusual to see a separation in the AC joint, and you would pick that up, again, by getting an x-ray. One more point about shoulders, I guess, before we leave them, and it is about posterior shoulder pain. I told you that typically this is not a shoulder problem. There are some shoulder problems that produce posterior pain, but they are not common. When a patient comes in with posterior shoulder pain, the first thing you probably should consider is that that patient has a neck issue, and you'd work them up with that. The reason I said maybe, our last point about shoulders, is because you have got to know about something called extrinsic shoulder pain. Extrinsic shoulder pain means the patient thinks the pain is in the shoulder, but that's not their problem. It's coming from somewhere else. So let me give you an example, and I'll tell you about one of my patients. I have a patient who is a painter. He has painted for probably 30 years. He came in to see me, and his complaint was left shoulder pain. And so I asked him, what do you do that makes your shoulder hurt? And the reason you should always ask that question is because of this fact. And it's a great pearl for me, and I'll tell you why it saved my professional life. So listen, orthopedic pain should always be reproducible. It should. Orthopedic pain should always be reproducible. So here comes my patient. He's complaining of left shoulder pain. He's left-handed, which is a question you always ask and document. What hand dominant is he? I'm telling you that will save you money in works comp. It'll save you money in a lawsuit. You make sure you document what hand dominant they are. So I'm talking to this guy, and he has a famous family member who plays professional football. So we are always talking football. So he comes in, it's his left shoulder. I'm asking him, what do you do that makes your shoulder hurt? He said, it's always when I paint. I said, is it when you paint walls or is it when you paint trim? He said, oh no, it's when I paint walls. It never happens if I paint trim. So I make him jump off the exam table. I told him, show me what you do that makes your shoulder hurt. So he picks up an imaginary roller, and he's going up and down in the exam room wall. And so we're talking about his famous family member. And I'm asking him, does your shoulder hurt yet? He said, not a bit. I said, roll the ceiling. So now he's rolling the ceiling. He's got the walls. He got the whole exam room covered. I said, you don't have any pain? He said, not a bit. I said, come see. I get him into the middle of the exam room. This man's got shoulder range of motion like a windmill. He can go in any direction, everywhere, no decrease in his range of motion. I could not reproduce his shoulder pain. That pearl that I gave you, to me, was huge. Because of some other risk factors that this man had, I looked at him and I said, you know what? I think I want to send you to cardiology. He said, cardiology, you mean my heart? I said, yeah, I want somebody to look at you. Maybe that's angina. So he got in to see the cardiologist that afternoon. Now, how do you think he did that? He paints for the cardiologist, all right? So he goes in. He failed his stress test. I mean, failed it flat. He was on the table the next morning getting an angiogram. The guy ended up having a left main lesion. I never would have picked that up. Never in a million years. The guy would have dropped dead, and I'd have felt like I committed professional suicide because I missed it. And I probably wouldn't have, but I'd have felt terrible about it. The point is, pain in the shoulder can be extrinsic. And your clue that it is extrinsic is that you can't reproduce it, all right? If you can't reproduce pain, it has got to be, you got to stretch your differential and think of something else. Everybody with me? Let's talk about tendinitis or epicondylitis. I'm going to have you find your own epicondyle. Here is where pain radiates if you have lateral epicondylitis. You see it? All right, so here is your lateral epicondyle. I want you to find it right now, and you'll find it right here. And if you've got lateral epicondylitis, when you apply pressure right over the lateral epicondyle, you'll have pain right away, and boom, you got your diagnosis. So this is a pretty easy diagnosis to make. That's tennis elbow, right? Lateral epicondylitis. Golfer's elbow is medial epicondylitis. So the medial epicondyle is right here. Pain radiates this way into the lower arm. And if you apply pressure right over your medial epicondyle, You got it? Put your elbow at a 90-degree angle. Put your thumb right there over the medial epicondyle. If you've got medial epicondylitis, when you apply pressure, you'll pull away and say, oh, yeah, right there. So this is an easy diagnosis to make. Suppose you were to see a question like that on the exam, and the question asked, do you need to get an x-ray to make this diagnosis? What is your answer? Absolutely not. It is strictly based, or can be, on clinical exam. So how do we help these people? If you have epicondylitis, I'll bet you have an overuse injury. So you need to find out from the patient what they are doing that has caused this problem. Maybe they're refinishing a room. Maybe they've just started to paint and they don't usually paint. They've done some new activity at home, and that may be what it is, but here's how you get them better. You want them to rest from whatever the precipitating activity was, but you also want to make sure that you use ice 24 to 48 hours. We typically move to heat. Consider NSAIDs, maybe a steroid injection, PT, but to be honest with you, rest from the offending activity typically is beneficial in patients who have overuse injuries. I think you might see this on your exam, and I know you'll see it in practice, and we're going to see a lot of it in about 60 seconds when I ask you to do this. It is called de Quervain's tenosynovitis. It's an overuse injury that involves the wrist, and the cardinal complaint or symptom is dorsal thumb pain, meaning pain right here in the dorsal area of the thumb. The reason I know we're getting ready to see a lot of it in this room is because everybody in this room is engaging in an activity that I think will cause this. So look, here's what I want you to do. Put a star by the term Finkelstein test. I think you'll see that one again. When a patient has a positive Finkelstein, it makes us think of tenosynovitis, and here's how you do it. I want you to put your thumb in the palm of your hand and wrap your other 4 fingers around it. Now, this is where you are. I want you to take the fist that you just made and move it away from your body. How many people have dorsal thumb pain? Would you raise your hand? Look around this room. Look at how many people in this room. So what are you all doing that's precipitated this? You are a student, right? So you have these 3 fingers, you grasp and you write and you write and you write. And so, how do we help these people? Well, when they're NP students, we get them graduated, because when they graduate, it goes away. So that's what we do. But listen, obviously rest and honestly, our same little recipe that we use for most overuse injuries. I'll tell you something right now. There are 2 things that if you malpractice in, you'll get sued, and you're going to lose. The 2 most common places for docs, PAs, and NPs to get sued on are malpractice on hands, especially if it results in your patient not being able to use one, or if you malpractice on a face, especially an eye. So I want you to take a look at something. There is a bone in your wrist and mine called the scaphoid. It is right here. It might be the most important bone in your hand because it stabilizes your wrist. Unfortunately, it is easily injured when people fall on an outstretched hand. So look at this. Actually, this is one of my patients. A shopper fell at the mall on her extended hand and on her wrist and fractured her left scaphoid. What is a classic complaint? This is what she came in with, and this is how I think this is what you have. What's a classic complaint for scaphoid fracture? Okay, look. Dull wrist pain with squeezing. All right, so she got up off the floor at the mall very quickly because she was embarrassed. She picked up her bags, and as she began to squeeze and hold the bags that she was using to shop in, that's when she began to have wrist pain. So it's dull wrist pain with squeezing is a classic complaint. The way that you will assess a patient in whom you suspect a scaphoid fracture is always with something called snuff box tenderness. Now, I want you to find your snuff box, and the way you do it is by putting your hand out like this, as if you're telling somebody, stop! Move your thumb medially. Now, you should see your your snuff box. You got it? If you have a lot of tissue around your wrist, you might not see it, but you can feel it. All right? So either see or feel your snuff box. If you have tenderness and pain after trauma in the snuff box, you are presumed to have a scaphoid fracture until proven otherwise. So what will you do? If you have positive snuff box, you need to send that patient for an x-ray, and you hope you get a good rad tech. Because to get a good picture of the scaphoid bone takes somebody who's got good skill. It is not unusual for the initial x-ray to be negative, even with a scaphoid fracture that is present. Consequently, if this x-ray comes back negative, it is considered a good idea either to get them referred to ortho for evaluation or to immobilize them in a thumb spica splint and re-x-ray 3, 5, 7 days later and see what it looks like. And I would encourage you to do that, all right? Because you never want to miss a scaphoid fracture. They don't heal well when they're not treated initially, all right? Let's move to the spine and talk about low back pain. And I would be willing to bet that everybody in this room has had low back pain. If you haven't, please come see me afterwards because it's extraordinarily common. So when a patient comes in with a complaint of low back pain, I think the most important thing for you to do is get an excellent history from them. And the reason I tell you that is because sometimes people who come in with low back pain have a systemic disease. Look, clues to systemic disease when the patient has a complaint of low back pain. Anybody with a history of cancer with low back pain gets an x-ray. Anybody with low back pain who's over 50 gets an x-ray. Certainly anybody with low back pain and unexplained weight loss gets an x-ray. These instances are the time when we do get an imaging study with low back pain, because outside these 5 things, we almost never get an x-ray, right, with low back pain. We almost never do. These are the times that you will get one. So again, critically important to get a good history. A common form of back pain, and I'm willing to bet most people in this room have had at least some episode of it, is called sciatica. Sciatica is nerve root tenderness, all right? Nerve root irritation, and the word we use to describe this is called sciatica. A common complaint from these patients is that there is a pain or burning or pulling down the side of the leg or even the back of the leg, and it might even be accompanied by numbness or tingling, but almost always it goes below the knee, all right? The 2 places or area discs that are most commonly involved in sciatica is a disc between L5 and S1 and the disc between L4 and L5. That pushes on those nerves and precipitates episodes of sciatica. So how might you evaluate this patient? Your exam loves to ask about straight leg raises, and I would say it's not a bad test. It's certainly easy, quick, cheap. You can do it in your office. What we look for with a straight leg raise is that you, the examiner, look at the patient and say, let me have the weight of your leg. Don't let the patient lift his leg. You tell me, watch, just relax. Let me have the weight of your leg. When you do that, what I want you to do with an extended, a straight knee like this one, is to very slowly increase the leg, just as you see it. A positive straight leg raise means you elicited pain down the side of the leg somewhere between, look, here's 10 degrees and 60 degrees. So this is not somebody who's got to go to 90 degrees for you to get pain. 10 degrees to 60 degrees, if you can reproduce the pain that they're having pulling down their leg, it is considered a positive straight leg raise. It might confirm radiculopathy. It's not the best test in the world, but it's quick, cheap, non-invasive, and we do a lot of it in the office. What about a cross leg raise? What does that mean? It means you use the unaffected leg. That's the one where you say, listen, let me have the weight of your leg. No, don't help me. Let me do it. Let me do it. And slowly raise the leg. And if raising the unaffected leg produces sciatica in the other leg, it is considered a positive cross straight leg, all right? A cross leg raise. So this one, again, you'll be able to do very easy. The good news about low back pain is that by early mobility and just conservative treatment, the vast majority of people get better. They never get better as fast as they would like to, right? They want to get well tomorrow, before the end of the week, and sometimes this takes a few weeks. So look at how you'll manage them. Early mobility is huge. Give them something that helps with their pain to get them up and moving, and that's what we'd like to do. So again, consider that. Most people have resolution of their low back pain, especially sciatica, within 4 weeks, even up to 6. What is a story on imaging studies? I gave you the 5 instances when you may want to get an x-ray for low back pain when we almost never get it. But this is what you should consider. Imaging studies are never recommended within the first 4 to 6 weeks unless there are red flags. Those 4 or 5 instances I gave you are examples of red flags, but so are neurodeficits, progressive neuro symptoms, weakness. All of those should prompt you right away, even within 4 to 6 weeks, certainly to get another one. I'll tell you right now, with insurance companies and on your exam, you're going to have to get an x-ray, an AP and lateral lumbosacral spine. You usually have to get that first. When they say, oh yeah, that's negative, but my patient has persistent pain, then you typically can get an MRI or CT, depending on what you're looking for. All right. So imaging studies are expensive. Don't forget that they impart radiation to patients, not MRIs, but certainly CTs and X-rays. And so this is my deal. Quick, cheap, non-invasive. You can do it in your office. It's always the best answer on the exam, and it usually is what you have to do before you get one of those more expensive tests. What about hip pain? When a patient comes in with a complaint of hip pain, there are 2 things that I think will help you identify the etiology. One is to find out the location of the pain. Where? Is it anterior hip? Is it lateral? What is it? And then the character of the pain. So let's take a look. Here is your first patient. A 58-year-old female reports that she started experiencing, lateral hip pain a few days ago. She's unable to lie at nighttime on the affected side. Now, I'll tell you right now, she's telling you what she's got. What does she have? She's got bursitis. In fact, I'm willing to bet you she's got trochanteric bursitis. How will you identify that? You take the palm of your hand, you apply pressure right over the trochanteric bursa, and you reproduce her pain. And that's a pretty easy one to make. So listen, I made a chart for you. This shows you the location of her hip pain, or anybody's hip pain, and what diagnostic considerations you should have. Well, we just talked about lateral hip pain. Trochanteric bursitis is like the poster child for that one. Pain that's better with use, pain with use and better with rest. We talked about it earlier. What was it? Osteoarthritis. Constant pain, especially at nighttime. If they don't have it during the daytime, red flags ought to go up for you. Nighttime back pain that does not occur during the day should make you think of something neoplastic, inflammatory, infectious. That's never a good pain. And then finally, for people that have anterior hip pain, I'm always amazed at who doesn't know this. What's the most common presentation of osteoarthritis in the hip? It is anterior groin pain. You got it? So people will tell you, when I bend down to tie my shoes, oh my goodness, I get this terrible pain right here in my groin. Men who have that pain think they have some testicular, scrotal, abdominal something or other. They think they got something bad. That's a common presentation of osteoarthritis in the hip. So again, consider that. Posterior hip pain, you need to think about an SI joint or something going on with the lower back. All right? So the place where the hip pain occurs will be a big clue to you as to what the etiology will be. So look at this patient. It's a 48-year-old male who works as a carpenter who complains of left groin pain. Range of motion of his hip and leg do not elicit the pain. Red flag? Big red flag, right? You can't reduce his pain. What's a likely diagnosis? Anybody think it's an inguinal hernia? You should. If it was one of these other orthopedic issues, you should be able to reproduce it. The non-orthopedic choice is number 3, an inguinal hernia. What about an ankle sprain? I stole a piece of your paper, I have to tell you. I kept waiting for the owner of the tablet to come, and you didn't come, so I took one. It'd be all right? Okay, good. So listen, in the United States, we grade ankle sprains kind of like this. A grade 1 sprain is, a minimally torn ligament, but we have a stable joint. A grade 2 sprain is a more severely torn ligament, but we have a stable joint. Look at a grade 3 sprain. We no longer have a stable joint. These always get referred. It results in a complete rupture, and those are usually pretty easy to pick up. Patients can almost never bear weight on a grade 3 sprain. So listen, the two that you're going to see in your office all the time is not the grade 1. People walk on that and they do fine. The grade 2s, excuse me, and grade 3s are the ones that come into your office. Grade 2s you can help. The grade 3s you need to send over to ortho because somebody will need to figure out whether they need to do a surgical procedure. So how do we manage sprains regardless of the joint that's involved? The acronym we use is RICE, Rest, Ice, Compression, Elevation. We're about to get a new acronym. The new acronym might be POLICE. It involves this, but what it really involves is early mobility, especially with splints and braces, because we have loads of data that show that when we get sprains mobile very early, like within 24 hours of the event, that patients do much better a whole lot faster. So here's your next patient. A 48-year-old nurse complains of pain in the center of her heel with activity, but especially when she gets up from a sitting position or first thing in the morning. My question is, do you know what she's got? You're thinking plantar fasciitis. Good thought. In what position should her foot and heel be examined to make this diagnosis? It is always with the foot dorsiflexed, right? Circle number 3, I'll show you what it looks like. If you suspect plantar fasciitis in this patient, the classic complaint is point tenderness at the heel. To do that, what you've got to do is dorsiflex the foot. When you dorsiflex the patient's foot, you will make this plantar fascia very pronounced so that when you touch it, you will be able to reproduce the pain. So what's a plantar fascia? The fascia is this thick fibrous band that goes underneath the foot. It goes right here, and it can become inflamed. And when it does, it is a nuisance to people who get it. It can be crippling sometimes because it's just so miserable. Sometimes we see this in patients who are very heavy. Sometimes we see this in patients who wear broken down shoes. Sometimes we see this in patients who have to operate or walk and move many, many hours a day on very hard surfaces. You got it? And if you have broken down shoes and you're heavy and you're on a hard surface, you are begging to get a case of plantar fasciitis. Sometimes plantar fasciitis is secondary to a spur that forms. So if your initial interventions don't help, or maybe even initially, you may get an x-ray which will identify that spur, and you'll realize, you know what, the spur needs to go or get injected in order for this patient to improve. Another foot problem that I think you may see a question about on the exam is Martin's neuroma. A neuroma is a little benign nerve tumor, but it is exquisitely tender when patients have it. So it's typically caused by compression of the nerve, and I'll show you what we look at. The test that we use to diagnose this is the MTP squeeze test. And when you do the MTP squeeze test, you'll take your hand and squeeze those metatarsal heads together. If there's a neuroma right there, when you squeeze, you better get out of the way, because the patient is going to kick you because you have just reproduced this burning, horrible pain in their foot, and they're not going to like you very much. The most common place for a neuroma to form is between the third and fourth toe, but to be honest, it can form between the second and third. It can form anywhere where there's pressure and compression on that nerve. Changing gears a little bit is a March fracture. Another name that you know is a stress fracture, and it's an overuse injury to a bone. If you get an x-ray in one of these patients, it almost never shows a fracture, at least initially. A bone scan might identify it, but that's a darn expensive way to diagnose it. Typically, this is a clinical diagnosis. So I got a quiz for you. Here's a patient who's got, and you diagnosed with a March fracture, a stress fracture. 2 to 3 weeks later, after complaint of pain, you x-ray this patient, and here's what the report says. Periosteal elevation, cortical thickening, sclerosis, and the presence of a fracture line. What does that x-ray finding mean? It means they had a stress fracture, and you will begin to see the presence of the fracture as the fracture begins to fill in. So what this is telling you is there's filling in of the fracture line. So initially on x-ray, it's almost always negative because the fracture is so minute you don't see it. Once you begin to get bone laying down in that place where the fracture occurred, then you x-ray it. This is a report you'll get, and then you'll say, yes, I was right. You had a stress fracture. What about knee pain? Well, there are two reasons why people commonly have acute knee pain. One of them is from a meniscal tear, and in most people it occurs with a plant and a twist, all right, and that can tear a meniscus. But in your older adults, it doesn't always happen as an acute event. Let me give you an example. You might have a little old lady who's pushing her grocery basket down the aisle of the grocery store. She plants, turns her grocery basket to go down this next aisle. She may have just torn a meniscus. So look, pretend that my 3 fingers are a meniscus. If you tear a piece of the meniscus, as long as the torn piece comes back right in line with the piece it was torn from, you will be able to move without pain. A lot of times that happens in older adults. If the piece of meniscus is torn and it does not return to the place it was torn from, there will be acute, exquisite pain anytime the joint tries to move. That's what usually happens in athletes. They tear a meniscus and they know right away. In our middle and older adults, very often it happens as an event they just don't recall. But that's a common example. It's really a degenerative tear. Torn ligaments, on the other hand, can produce acute knee pain. Almost always is a very memorable event. And so to evaluate the laxity of ligaments in the knee, we have 2 tests that I think you'll profit from watching this video on. I think if you see what a positive anterior drawer and a positive posterior drawer look like, I think you'll always remember it. So let me show you this video. I'm going to show you what a positive anterior drawer test looks like first. And what I would tell you is the place where they are should give you a clue about the severity of this injury. All right, they're in the OR, so you know it's going to be positive. If you want to assess the integrity of the anterior cruciate ligament, the anterior cruciates, look, are right here. You see them? If you want to assess the integrity of those ligaments, what you must do is immobilize the foot so that when you pull to create an open anterior drawer, all of the stress is on the anterior cruciate ligaments. So look at what it looks like when it is positive. You ready? Watch. Open. The drawer opens. You see it? So that's an example of a positive anterior cruciate ligament or a positive anterior drawer test. Now I want you to look at what a positive posterior drawer looks like. I want you to notice where these people are. They are in an exam room. A couple of things to point out. One is if we're going to assess the integrity of the posterior cruciate ligaments back here, again, we have to immobilize the foot because when you push to create the posterior drawer, you need to make sure that all the stress is on those posterior ligaments. Now, a couple of things to note. One is that this guy has already had a knee problem. You see it? He's going to be in the market for a new knee before very long. The second point I want to make is you know this guy, the examiner, has got to be an orthopedic doc. One, because he's got huge hands. I always think, thank God he didn't go into GYN, but all right. And then the real reason you know this guy is an orthopedic doc is because he's got an expensive suit. And you know that orthopedic docs are the highest paid docs on the block, right? It's not cardiologists, it's not CV surgeons, it is orthopedic docs. So take a look at what a positive posterior drawer looks like. Watch. Posterior drawer, you see back here? Okay, so that's what we have. And to me, once you see it, you got it. All right, so here's what we're going to do. We just went through a load of material. For the load of material that we just went through, here's what you need to know. You need to know what might predispose you to that whatever. What predisposes you to plantar fasciitis? What predisposes you to epicondylitis? What are the presenting signs and symptoms? Is it pain? Is it swelling? Is it tenderness? You need to know how to diagnose it. And if you can do a test in an exam room, that's the right answer. And then finally, how do you get these people better? That's what you need to know.